mapping. Luis, are you ready? Yes, good morning. From room 4 with Dr. Andrea, Natale, and Diego Rodriguez. We would like to present the case first. This case is a 45-year-old male patient with 8 years of non-sustained palpitations despite treatment with beta blockers and antiarrhythmic drugs without achieving proper control of the palpitations. There is no history of pathology. The treatment was amiodarone 200 milligrams per day and metoprolol 50 milligrams twice a day. A Holter was done that showed monomorphic PVC 45%, an echo with an ejection fraction of 44%. We did coronary arteriography, which resulted negative. Chagas test was also negative. On this slide, you can see the morphology of the extrasystole. The patient was bigeminal. Give me a second, please, Luis. No, Luis, just a minute, please. We're going to go further into the description of the ECG. As you will see through the day, this is the key step when we are planning what we are going to do in the OR. Let's say that one of the basic tips is not to fully analyze the extrasystole initially. Let's analyze the sinus rhythm first. The sinus rhythm is telling us the story of the patient, whether the patient has heart disease, and this is what we intend to do initially. In this case, you can see the sinus rhythm. I see a Q wave in lower leads that don't meet the criteria of a necrotic wave. And it's very important in terms of interpreting the origin of the extrasystole. We must understand where the forces are transitioning in the sinus rhythm. We know that that's essential, particularly when we want to differentiate extrasystole from the right cusp or the outflow tract of the right ventricle. So it's very important for you to keep in mind that point, because the comparison of what transitions first in this type of morphology, whether the extrasystole transitions first at the sinus or vice versa, that could indicate in a way where the extrasystole comes from. So please keep this morphology in mind. And in fact, we see that we must follow a specific order to describe it. The recommended order is to start with the V1 analysis. You describe the morphology in V1, and we see that it's a morphology of left branch block. Then we see the transition. It's transitioning towards P3. The QRS is already positive. And then we go to C. We see that the axis is superior, and somehow it's biphasic in B1. This type of morphologies, of course, guide us towards a specific differential diagnosis, and this is the key exercise, not just in sinus, but in extrasystole, based in the morphology, to try to establish 3 or 4 differential diagnoses to save time during the procedure. Of course, if in general terms, the easiest conclusion is that if there is a lower axis, as we can see in this extrasystole morphology, obviously we won't waste time mapping the lower wall, the inferior structures, the apex, etc. Here, this is pointing to a high structure, which obviously represents the outflow tracts. So this is an exercise we will continue throughout the case presentation. But keep in mind at least 3 differential diagnoses where you are going to place your catheters for mapping and where you are going to focus your efforts to save time. Well, Dr. Sainz was saying these are the extrasystole. Remember the morphology. And after completing the analysis, let's begin to think about the localization site. Please remember to open your app, the voting zone. I think that everybody's now connected to the network. You don't need any passwords or anything. So let's cast your votes. With the Cusps, we may now read the answers. The anterolateral wall of the outflow tract. Can we go back to the presentation? We are doing the electrocardiographic analysis of the extrasystole. Okay, so based on the morphology we just saw, most of you suggest that the extrasystole comes from the right coronary cusp, and the rest of you are distributed among the other options. Luis, could you please go back? Can you go back to the extrasystole? I would say that the most important points in the analysis is, of course, the axis. The axis is quite low. Probably these are the outflow tracts, and we have to differentiate where we are, whether it's the right side or the left side, etc. It's very important to analyze AVR and AVL, because when we have negative AVR and AVL, that means that the origin is very high in order for both to be negative. When the origins of these arrhythmias start to drop in the tracts, that's when AVR can become negative, AVL can become isodiphasic and positive. So this pattern and the large voltage indicates that this is a very high structure in the heart, and according to the transition analysis, we have to differentiate whether it's in the right coronary cusp or the septal aspect of the outflow tract of the right ventricle. There are some additional analysis that we can make, and it's very important to do them. It's the analysis of D1 and also the analysis in terms of the balance of the vector between AVR and AVL. When we have extrasystole of this morphology, but mostly negative in AVR, that tells us that probably the depolarization vector goes from right to left. And usually we have more positive vectors in E1. So the extrasystole here is mostly more negative in AVR than in AVL. And as far as I can see, are more positive in D3 than in D2. So this may suggest that this extrasystole could be localized as a differential diagnosis either in the outflow tract of the right ventricle in the septal region. That should be a differential diagnosis because of the early transition, but most likely towards the most anterior aspect of that septal segment of the tract, so that AVL will be more negative than AVR. As a differential diagnosis, we must also consider that it can come from a structure in the opposite side. It could be the outflow tract of the left ventricle. And we will further clarify that studying the map. Okay, so let's continue after casting our votes. The patient underwent a Holter, as we discussed previously, with very frequent ventricular ectopy with a 45% load. We did the ECG. This is the result of the echocardiography. Mild. No, we just presented the case. You have seen that the patient has an ejection fraction of 40%, very high extrasystole, 40% if I am not mistaken. And obviously, part of the exercise is do the clinical diagnosis of the patient. Well, I finished the case presentation, so, well, obviously we don't know whether this patient has heart disease, and one of the manifestations is extrasystole secondary to heart disease, or eventually such a frequent extrasystole that it's dilating the patient, and this is called extrasystole-induced heart disease. Later on, we can further discuss the differentiation between both scenarios or settings, which is fundamental for decision-making in these patients. Do you have anything else, Diego? Well, I don't know whether we can show on the screen a CARTO. Yeah, the mapping system. This is the other CARTO screen.
No, ese es el polígrafo.
No, that's the polygraph. The other CARTO screen, please. We can show on this screen the passage. Can we show the passage on this screen? Let's, well, at this time, as you can see on the echo to the right, you can see the catheter that has been placed in the coronary cusp. Well, one interruption. The ECG that you are showing has differences with the ECG, with the clinical ECG that we showed us, unless there is a mistake with the leads, because this is a left branch block with an early transition towards B3, but lead 1 is positive with a lower axis, but we no longer see the negative prevalence that we saw before in AV. So probably it's more positive D2 than D3, and probably more negative AVR than AVL. So this changes the situation, because if we have a lower axis, but it moves to the left because D1 is positive, the only one to explain D1 positive is that it goes from right to left, but D2 more positive than D3. So it has to be either in a septal structure, the outflow tract of the right ventricle septally, because it's an early transition and from right to left. So it should be more septal posterior, or on the opposite side. I will show some anatomy slides. This is the outflow tract of the right ventricle. This is the pulmonary valve. This is the septal wall, but remember that this is not a real septum. And the differential diagnosis should be in the opposite structure. It should be either here or in the right cusp. And this is an ECG which is more suggestive of right cusp. So I think this is a good clarification. Very well, Diego, you can go on. Well, I was saying that in the echo, you can see the catheter towards the right coronary cusp. We are in the home view. We try to pass the intracardiac echo catheter to the right ventricle in the short axis to identify the coronary cusps. Here we see the catheter towards the right coronary cusp. Here you can see a green dot, which is intermittent and is consistent with the tip of the catheter. In the upper right side, you see the right coronary cusp down the left coronary cusp, and you can clearly see the origin of the anterior descending artery. And to the left, you see the non-coronary cusp. At this side, well, let me explain something to complement. Remember that there are two ways to present the image in intracardiac echography. If you see the slides from Pennsylvania University, they always put the sign to the left. You will see the images just the other way around. Most labs put it on this side. So whenever you read a paper or images from presenters, please keep that in mind. Remember that in this way of seeing things here, you can recognize the structures that help you to remind you which cusp you are in, because that's fundamental. You need to find where the tip of the catheter is. So the left cusp is the one next to the left main. Yeah, the left coronary artery. Here you can see the appendage, the ridge, and the superior pulmonary vein. So this helps us to differentiate the cusp up here. Here we should have the tricuspid, and this is the pulmonary valve. This should be the right coronary cusp, and the one against the atrium is the non-coronary cusp. Well, the 3 points we have taken from the right coronary cusp, I was more extrasystole were being developed. Can we see the right coronary cusp? Here. I would like to have all the points targeting the right coronary cusp. This is what you see here, the right coronary cusp. Something important in echography, everything guided by intracardiac ultrasound requires you to see the tip of the needle or the tip of the catheter if you are mapping, because you can see the shaft of the catheter here, but that does not necessarily mean that the tip is over here. It can be in another cusp. It can be in the coronary as well. So with this CARTO technology, this green tip indicates exactly the green circle where the tip is located. That is pretty reliable. And with other technologies, you have to rotate from clockwise to counterclockwise. Could you show, please, the review screen for CARTO? The patient was beginning to develop more extrasystole. As you see in the upper left image, apparently there is earlier development of extrasystole in the right coronary artery. So maybe we can take a look at that area. Yes, and please use unipolar. Well, this is a PACE map, which was done at this site when the patient was not doing a ventricular extrasystole. So we have a PACE map of 87%. Down to the right, what you see now is the extrasystole that the patient is presenting at this point with minus 21 milliseconds. Can we place the unipolar here? Well, can you show us where is the passage? Where is the exact site of the passage? Where did we do the passage? Well, can you show it in the map? It is highlighted here. Yes, we can see it now. This is the site for the passage. We had 87%. Diego, let me explain something about passage. Those of you who are not familiar with the technology, passage or PASO is the name of the software. It's an automated algorithm to compare morphologies. There are different kinds of algorithms. Most of those algorithms are based on two aspects. They compare the amplitude of each lead, and they also compare deflections. So they establish a correlation coefficient, lead by lead. Show us the PASO again. And let's see the comparative. So we take a template from the extrasystole. Can we see the PASO? Well, in fact, Luis, let me show you the way we use the PASO. We can do the PASO at this point so that you can see it now. Diego, take one PASO point. At this site, we are going to do a PASO. and compare. So the software is showing here the average correlation coefficient lead by lead. But this is very important for every comparison algorithm, and in general, what we do in clinical practice, even when we did not have these algorithms. More important than the average itself is how much is the average lead by lead. These algorithms have sensitivity and specificity. Well, here we are at the point for PASO. We are going to pace now. We are pacing at this point at 500 milliseconds. Can you record the pacing, please, Diego? Perfect. And at this point, we have 0.873. It's pretty good. It's not the ideal percentage, however, but it's quite acceptable. How much are we pacing, Marcela? What's the rate of pacing? 10. We are pacing at 10. 10 for the outlet. With the electrogram, we can see the CARTO screen. Diego, I would like to ask something to Andrea. Yes, Andrea is listening to you. ¿Cuál es su opinión, Andrea, acerca de la especificidad y la sensibilidad de este tipo de software automatizado para comparar la morfología espontánea versus la morfología estimulada? Hay que utilizar ambas, porque tanto la activación en un paciente con corazón normal se puede propagar rápidamente por un área extensa, y también en la cúspide, cuando ustedes estimulan, capturan otros tejidos. Entonces hay que combinar ambas informaciones. Nuestra observación es que cuando usted está utilizando este tipo de software, hay que recordar que hay cierta parte del corazón, hay ciertas partes en el corazón, especialmente cuando hablamos de tracto de salida y PVC, donde el mapeo de la estimulación puede ayudar mejor en algunas partes que en otras, especialmente en cúspide. Se supone que hay como vías específicas de conducción preferencial, que algunas veces puede llevarnos a falsas conclusiones cuando hacemos la estimulación. ¿Algún comentario al respecto? El comentario es que cuando estamos utilizando
software to compare PVCs, and even when we are basing our approach in pace mapping, there is some parts of the outflow tracts, like cusps, that
sigue tomando
could be preferential conduction, and could in that way, pace mapping could mislead the procedure
Misleading,
in
yeah,
the
it
way
can
that
be
you
misleading,
can pace from the exit of the pathway, but you are not in the critical part, in the
Yes,
origin, or
absolutely.
vice versa. Any comment
Yes.
about it?
Yes, absolutely. Yes.
What is the place of the outflow tracts where you can feel better or safer about the information that the pace mapping is giving you, to guide your application over those places?
To be honest, I usually rely more on the activation than on the pacing. I think the pacing become also more a fallback when the PVC are rare. But I really rely more on the activation.
Andrea, let me explain to the audience at this point, Andrea. Esto es muy importante. Lo que estaba mencionando el doctor
what
Natale.
Dr. Natale is saying. Whilst these algorithms are very helpful, obviously we must keep in mind that algorithms have limitations. But those limitations are also related to the pace mapping itself. Remember that depending on pace mapping, whether it's unipolar or bipolar, specificity can be higher, and also depending on the rate of stimulation, of the rate of pacing, you can get some misleading information because you capture not just the local tissue but neighboring tissue, and that can be confounding for the information because you are capturing a broader front. So PASO is a useful tool, but it's complementary to the cases. The best thing to do always for all of us is that procedures must be guided as much as possible by activation. Activation should guide us, and this leads us to an important point to keep in mind. We have to establish the specificity of the activation mapping versus pacing. When we speak about the specificity, when you do an activation map, usually you have approximately 1 centimeter, 1.5 centimeters of zones or areas where all the records give you the same early activation time. So in the end, that's the density. That's the specificity. But when you do pacing, that may increase up to 2.5 centimeters. So in an area of 2.5 centimeters, you can have exactly the same pacing. And that's important to remember because these are the limitations we have. And when you guide a procedure exclusively through pacing, the procedure may fail because you could be at the extreme of those 2.5 centimeters of area, giving a good pacing, but not necessarily at the source. Okay, can we see the CARTO screen of PRUCA on the main screen so that we can show that screen to the audience? Well, for the time being, what we are doing is taking or doing the activation mapping of the extrasystole, which are now more frequent. This is one of the last extrasystole, and you can see the electrogram, the unipolar electrogram. We have not completed the map fully, but I would like to ask the audience, and you, Luis, would you think that this is a good application site, or will you go back to the right side? Which would be your strategy at this point? Well, I would like to hear your opinions, the opinion from the audience. Would you apply here? Would you map more? Would you go to the right outflow tract?
Keep on acquiring, please. First the right side and then the left side, probably. Well, there is a suggestion here that you should have mapped the right side first. That is the opposite side, the septal side of the RVOT. Yeah, because of ease, you play the catheters on the left. But you don't take much time. It's the concept of like coronary arteriography. If there is an infarction, you want to start seeing which is the culprit. You don't take more than 10 minutes in doing a rough map of the right side. It's a comparison, it's a comparative. The right cusp against the septal aspect of the pulmonary artery. Yeah, that's a comment. Diego, just a minute, there are more comments here. I agree. It doesn't take more than 5 or 10 minutes to do a right-sided map to have an idea. And I think that I would apply the 2 centimeters. It's true that the earliness of the ectopies in a healthy heart are not always a very good guide. Sometimes there are zero potentials in surface and the application is completely successful. I look for potentials of -30, -40. Diego, let me comment or let me convey the comments from the room so that you can make your own comments and replies over there. So you are all in favor that you would have gone first to the right side to do the mapping. There's another comment, and we'll go back to you to the lab. I would also agree, yes, that you should have started on the left side and not look at the right, because a very clear exercise has been done. The EKG will always be the basis for the approach. That area, specifically the level of earliness because of the thinning of the tissue, because the tissue is thin and it's only fibers, should be less than if we were on the right side. If we have all the criteria, the application would be there. Diego, the opinions are more or less divided regarding the fact that some people would have gone straight to the right side to the septal posterior portion of the RVOT to make some points there because it is something that can be done easily and quickly. And others say that if your deduction, your analysis, that there is a higher probability of the extrasystole coming from the right cusp and not the septum, then you don't do it. So let me say one thing. Probably the limitation in this case is that there are hardly any extrasystoles. It depends also on the technology, yes. So the truth is that with whatever technology you use, you need to save time. And if you're going to be doing something on the septal side, do something restricted. That is the key of doing the differential diagnosis, of having 2 or 3 differential diagnoses. Why? Because the obsession that we used to have, we started to map everything, the right ventricle, etc., and it would take a lot of time. What you simply need to do is, based on your deductive analysis, take some restricted points of this area and go to the other side, but bearing in mind the limitation that we're going to have because of the very scarce number of extrasystoles in this patient. Luis, question. First Carlos and then you. Based on everybody's real world, for example, we come from Venezuela. There are 4 people from Venezuela here, and our real world is that we do not have ice in the lab. That's the case for most of our EP labs. So I ask, for example, I do this type of, in this type of approach, I don't have intracardiac echocardiography. We don't have, at the present time, any TEE because of our political problems. So we inject in that area before we apply. What is your opinion? How do you do it? That is something that I understand that this is your real world. So what would you recommend for us? What could we do? Well, it's a very good point, Carlos. I would like to transfer that question to Andrea. To be honest, we do everything with ice, and we haven't done guided procedures. Of course, you can do them, but you have to have very good experience for the location, for determining in which cusp you are. Andrea. Luis, to close the topic on whether we would apply on the site where we were. When we started the case, we started by mapping the right side. We did start doing that, but on the right side, there were very few extrasystoles, and the ventricular excitability was really very important. So since there were no extrasystoles, we did a couple of pace maps which weren't very good. Then we went to the left side, and that is what you saw, the right coronary cusp really having a pass of 87% is a good pace map. But what we've seen with the pace maps is that ideally you should almost be above 97%, ideally, because with 87 at this point, I wouldn't apply. I think that we still need more mapping. and having more extrasystoles in the patient, we are going to start mapping the right side now. Diego, can you show the catheter in the RVOT? You went back to the RVOT. Yes. 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 I'm going to go back in the echo to the right side of the screen. You can see how the catheter is crossing the tricuspid valve, and it is advancing superiorly towards the RVOT. But of course, when we pass our intracardiac echo probe to the right ventricle and we place it on the outflow tract, it turned, it turned. Let me show you here. In fact, it's you can see the valve. The ice is an ideal method to distinguish the pressure of the valve, and this would be the free wall of the RVOT. You can see here to the side the aorta. We could start seeing the cusps if Diego helps us. Now he's deflecting the catheter. You see the catheter comes closer to the right cusp. Andrea, Dr. Natale, hay una pregunta aquí en el público acerca de sus recomendaciones para guiar el procedimiento con base en información.
In ICE, because there are some places in Latin America that don't have access to ICE technology. So can you show us the X-ray imaging and give us some clues about the X-ray orientation, please?
Por favor, en el cuarto de control nos ponen en la pantalla principal
I think the three-dimensional
fluoroscopio.
mapping system help, and you kind of try to go to the area in the outflow tract that face the right coronary cusp, which is right now the earliest point. The only problem we have with the right coronary cusp, the earliest spot that you see there, we think is an artifact. So I think the earliest site actually was more kind of towards the posterior side. But right now on the right side, we haven't seen anything earlier than.
Are you now in LAO? No,
Sorry.
00, AP view.
We are AP.
Yes, we're in
AP
P,
view.
or posterior.
Right. So please, when coming back to the cusp, remember to show us and to describe us some clues to be oriented about the cusp. What cusp, about the position of the cusp based on LA, RAO, etc. Bueno, Diego, Diego, vamos a tratar de conectar con la sala 3, un segundo.
The earliest point of the right cusp we want to see. Please show it to us and then we will connect with lab 3. Yes, we need to connect with lab 3. So please show us the activation from the right outflow tract for comparison. Okay, let us see the CARTO map again with the polygraph tracing. With the polygraph. This is what we are doing. We are mapping the RVOT. As I was telling you before, I think that we still need a lot of mapping in order to identify the area better. Apparently, the earliest area is the right coronary cusp, as is to be expected, opposed to the right coronary cusp. We have the right ventricular outflow tract and its septal portion. So that is where we need to define. Can you show us from a passage from the septal aspect of the RVOT, please? Can you take a point of pace map here? We haven't done a passage here yet, but we are doing it in a minute. While they take the point, well, there it is. Could you pace, please? Could you stimulate? Is that it? No. No, this is the only one that we have done on the right side. At first we did one, but this is the pace map which we just did. But this pace map is much better. 0.933. Yeah, but check that it is really captured, because accidentally this could be a spontaneous compared with another spontaneous, and the pacing may have shown a dissociation. Okay, just a second, we are going to repeat it then. Es un punto ligeramente diferente, dice el doctor Natale. We are going to take. La activación ahora es temprana. Aquí. No estamos capturando.
Toca una que esté capturada.
Creo que hay que deflectar un poquito más. Que
Deflect.
vector apunte.
Acá no está capturada.
No, it's not capturing.
Aumentale la salida un
Please
poquito.
increase the output to 15, please.
Pongamos en la otra pantalla en tiempo real.
In real time, in the other screen, please show us the true cap, the true cap, David. Podría ser the catheter may be above the valve and is not capturing, or it is not touching the septal portion. Now, the vector should point towards the cusp.
Acá se ve el eco.
Here you can see the eyes.
Y ahí estamos por encima de
We are above the valve.
Obviamente, el eco nos ayuda a guiar el
Eyes helps us guide the contact. We need to deflect much more than you would think. It's capturing here. Let us take this pace map point.
Maybe you are upper to the valve, right?
Tal vez están por encima de la válvula. Luis, here we have a pace map of 0.912. Yeah, but please ask the technician to move the lower bar to both sides to make sure that there was a capture. In this one, there was a capture. Yes, so let us show it. Let us show it. Can you move the lower bar, Jose David?
No lo sé. No lo sé.
I'm not sure. I'm not sure. I don't think there is a capture. Look at the spike. It is associated. People who are at the PRUCAP, could you give us real time, please?
Bueno, entre otras, para un segundito ahí, Diego.
Let us stop there. Stop there, Diego. Can we pace here again? Marcela.
Ahora hay captura. La perdieron.
Aquí no hay captura.
There's no capture here.
Capture here, Andrea. Estimula, por favor.
Please stimulate there, pace there.
Acá hay captura. Toma,
There
por
is
favor.
capture, yes.
Totally.
Okay.
Nos están mostrando el paso el antiguo.
You're showing us the older one, not the new one.
Muéstrame este último pace map.
Show me the last pace map.
¿Es este seguro?
Is it this one? Are you sure? No, that's not it. That's not it. This is the older one.
A ver, toma otra vez punto.
Take the point again for the 5th time.
¿Ya están listos para tomar?
Are you ready?
Estimula, Marcela.
Please, Marcela, pace.
¿Está capturando? ¿Está capturando?
Is it capturing?
Ahí,
Yes.
Ese es.
That's it. That's the one.
0.92.
0922.
Diego, hay que excluir las
But you need to exclude the spike from the comparison window. Yeah, that is true. You're right.
Ahí está.
There it is. There it is.
Bueno, si eso es cierto y está bien capturado,
Okay, if that is true and it is well captured, probably the friends who said that they needed to start on the right side might be right. Might be right, yes.
Mide acá la precaución.
Please measure the earliness here in the PRUCAP.
Lo que es que no se ve tan precoz, Luis, que
It doesn't look as early. It doesn't look as early. And we are discussing this with Andrea here. What's the earliness? Please update, Marcela.
¿cómo es la activación ahí, Diego?
What's the activation like there, Diego? Sometimes we obtain the same thing when we map the right and the left side. When we map the right side, the extrasystole continues, but the morphology in the one changes. Yeah, we totally agree. The observation given to us here, Diego, yes, Diego, it's very important for you to show us, because you may have a perfect passage and maybe the exit of a preferential conduction zone. Please place in the review screen for the polygraph. It says you may be in the exit but not the origin. You may be at the exit but not the origin. Yeah, here we need more support because the electrogram varies a lot. I cannot have a good, I cannot get a good measurement here. Please update. Well, taking the initial electrogram, for me, AVL was more negative than the AVR. Although in D1, I see that in D1 it is more negative. And although the transition is in V3, I would go to the left cusp. Here we have the image for this site. There is some earliness. It is not the best earliness. We have the feeling with Andrea that perhaps it's in the left side where we have the greatest earliness. But we agree that it has to be an area that you're seeing in the echo between the right cusp and the RVOT. So, which would be the approach? Do we go back to the left and start applying on the left side, or should we do some contralateral applications here? And probably we're going to end up doing them at the end of the day. Well, in general, the truth is that when you're there and you have a pace mapping and you have some activation, you make application. Any more questions? No, just a comment. The unipolar, I think that it's better on the right side or than the left side. I don't know if you can compare. Would you like to compare in the polygraph and the two-cup? The negative deflection is on the right side. When we come back to the laboratory, we're going to have that comparison. I feel that probably from the left side, I think that there is a good unipolar there that is starting in consistency with the other one. Well, we need to close with you. Chief Kumar is going to show some anatomy slides, which are very important to understand this. We go back to you after the break.
This is just, as they say, a commercial break. So we're going to do a teaching break for 30 seconds. I just wanted to show you one or two images just watching this case. And I really enjoyed the comment from the other gentleman about the question of intraseptal mapping. So let me just give you a little bit of an orientation of how we look at the anatomy of this particular region. So the heart, of course, is like, it's like the way you have to look at this is how Egyptian pharaohs are depicted with the RVOT coming over the LVOT. And if you look at this in 3D, this is the RV free wall that has been dissected and moved out. So if you look at that, I'll show this again for you. So if you open the RV free wall and open this out, this is how it looks in RVOT. Points to be made over here. If you look very carefully over here, the right ventricular myocardium wraps around the right aortic sinus, right? This is pulmonic valve, which is, of course, offset. And this is the free wall. So all these areas are areas from which you get VT. So keep focusing on this structure, and I'll show this to you both in fluoroscopic views because many of you are not used to ice, and I know Furman is a big fan of ice, as is Dr. Natale. We are big fans of ice, but we use any given technology as long as you understand how the heart functions. I'm going to show you one other dissection over here where the RV free wall is going to be dissected out. So we're going to cut out this part of the free wall and show you how the two outflow tracts relate to each other. So this is the free wall alone has been dissected out. This is a beautiful image because now you actually can see the left cusp and the right cusp, the sinuses. This is RCA, this is left main, and of course this is the branches of the coronaries. And this is the LAD running around the anterior interventricular septum, tricuspid valve, and this is RVOT wrapping around the aorta, right? Do you see this? This muscle, all these areas are areas from which you get VT. So how do you now relate this image in the EP lab when you're looking RAO, LAO? Here's an example where we have done dual power injections. This is injection into the PA, and this is a pigtail injecting in the aorta. So it's dual injection. This is RAO, this is LAO. So this is the plane of the septum. And of course, all this is atrial, this is ventricular. So you're looking at the interventricular septum directly face on. This is his RV catheter. So our strategy for this is, our playbook is to sample from some of these tough cases, especially like the one you're seeing here, where in lead V1, the R wave is fairly wide. These tend to be tricky cases. And they could come from anywhere of potentially 14 locations, in this outflow region where the two outflow tracts crisscross. So what you're going to be seeing is, the way Furman, Andrea, and I've worked with them for years, and the team here at FCI, the way they function, they are mentally making note of each one of these sites. And sometimes in our lab, even now, we sometimes make a note of it on a piece of paper in the control box because it gets to be a little confusing if you're just only making note of it in the electroanatomic system. So the question Dr. Sands made and the request from the audience was to look at fluoroscopic image. So this is kind of how the outflow tracts orient. So this is the same image I'm showing you now, RAO, LAO, and this is the catheter directly looking at the right-left junction. You see, this is our right coronary, this is the right-left junction. So keep this in mind in 3D when you're looking at the heart. So we have to look at two views and compute a third dimension in your mind. So this is another beautiful section which I particularly like because this is slicing the heart on the RVOT. And what you're going to be seeing over here is this is actually the right cusp. And this muscle that goes around the cusp is where we do the mapping, shown in higher amplification or magnification. This is the area that you're mapping. So it sort of wraps around. And sometimes you may not be able to map this area from the IVC, so you may have to even put up a Mullen sheet into the RV so that you can turn on yourself so you can sample these areas better. So this is another view again to show you how a catheter would look from the aorta and how it looks going from the IVC. So this is mapping the right-left junction from both sides. So perhaps I'll stop here and you can switch to the other lab, Louis. And someone wanted to know.
And what you have done so far. Okay. The details of the clinical history will be presented now. Good morning. I'm going to present the case. This is a 54-year-old female patient who presented with deterioration of functional class. She's at present 2/4 and also reports chest pain on exertion. On systems assessment, there's no syncope or palpitations. As a history, a diagnosis or she came referred with a diagnosis of dilated cardiomyopathy of non-ischemic origin, diagnosed for the first time 3 years ago. She has an ejection fraction of 35% at that time, with coronary arteriography without significant lesions, and a negative Chagas test. She has hypothyroidism and also paroxysmal atrial fibrillation, Chats-Vasc 2, sleep apnea, and pulmonary thromboembolism. She had been treated with carvedilol, which was discontinued a week ago, and also spironolactone, which was also, no, amiodarone, which was also discontinued. This is the EKG for the extrasystole, and here the sinus rhythm with incomplete right branch block. And here I show you the extrasystole, an extrasystole with left branch block morphology with early transition. The recent Holter test, 1,000 extrasystole with a burden of 18%, and you can see the different Holter tests, at least when she first presented with heart failure, with not a very large arrhythmic burden, so it is not induced by extrasystole. The EKG has an ejection fraction of 25% and a dilated left ventricle and an MRI scan, and the most important on cine assessment. Let me show you here on zoom in. The left side doesn't show enhancement, but in the magnified cine you can you have a non-contact myocardial, non-compact and greater than 2.3 to 1. The patient diagnosis, non-ischemic dilated cardiomyopathy, non-compact myocardium, 25% ejection fraction, frequent extrasystole, symptomatic with an 18% burden, which was suspected before she was brought into the OR, into the lab. Paroxysmal AFib, sleep apnea, hypothyroidism. Fermin, could you describe what you have been doing so far in the case?
Well, as you can see now, if you see the fluoroscopy, no, just a second. Can we see the fluoroscopy on the screen, please? Based on the ECG characteristics, it's not a typical extrasystole of the RVOT. There is a late extrasystole, and apparently with the R in UV1, it seemed to be from the LV summit, so we did a coronography of the coronary sinus, and then we inserted a multipolar catheter, 20 poles, in the distal coronary sinus and the anterior interventricular vein. So the first step is very important for the audience. When you suspect this, it's important to have access to the coronary sinus with a sheath. We are using an agilis of the coronary sinus. The interventricular vein can be seen very clearly. We use the agiles with the guide that comes with it, manipulating very carefully to get into the venous system. And the first step is to do a venogram to see how difficult it would be to use the catheters. Well, in terms of the LV summit tachycardia through the coronary sinus approach, it's interesting to see the anatomy of the perforating septal veins. This requires some adjustment from the fluoroscopy images. Here we see the right atrium flat. We can see the septal. We see the 20-pole catheter in the anterior interventricular vein. We see septal veins. Well, why don't you describe to us, Fermin, the type of catheter you are using, and how can that facilitate the procedure? This is a 3 French catheter. As you can see, it has a guide on the tip in order to avoid perforations. We are using the duodecapolar to try to span all the vein space. Essentially, the vein is an epicardic structure, as Miguel said. The idea is to place this catheter on the vein to map the epicardic component of the ventricle, as we did yesterday with the vein of Marshall. This is the epicardic component of the top of the ventricle, in this case the LV summit. We must stress something very important with this type of new technology available. One of the major limitations we had when we mapped extrasystole, and we suspect that they were related to the venous system, is that the French of catheters we usually use is much higher. We use higher French numbers, but those catheters were more stiff. And in many cases published and presentations that we saw, the earlier we had was approximately when the anterior interventricular reached the large cardiac vein. And if you only take that information, that would look like the earliest activation zone. This is the reason why with Dr. Fermin and our group, we described the technique of using guides to do unipolar pacing guides. But he's complemented that with the use of this catheter, which, as he said, is 3 French. What's the brand name of the catheter? ATT, it's an American company, and I can give you the name at the end of the meeting. But basically Fermin, go on. We are mapping the epicardium as the first step. So show us the first image, only the duodecapolar catheter. Show us the fluoroscopy and the review or the revision electrogram. So the first image of the duodecapolar, that's the wrong lab? No. The revision electrograms, not the live, but the revision electrograms. Here. Well, this is the first thing we did, and this is important about this technique. First, the electro is somewhat different from the extrasystole that Carlos showed us. Probably this is only due to the position of the leads or the electrodes, but what's important is to show before anything else, which is the most appropriate approach for this case, based on the activation of a catheter. So place the marker at the beginning of the QRS to the earliest phase, which is 1314. 1314 is the earliest. It is bracketed in 1314 and at the beginning of the ECG. So here you can see that in the 1314 electrode, we have activation of 39 milliseconds pre-QRS. And that makes us think that the 1314 lead is very close to the early activation of this extrasystole. That places you in the epicardic segment of the top of the left ventricle. It's not even the LV summit. The LV summit would be the 6th electrode. Here we are going down to number 7. Fermin, can you explain to us the order in which the electrograms are placed in the polygraph? Apparently this goes from distal to proximal of the catheter. So in order to orient yourselves, well, the easiest way to know this is that when you see the dicapolar video, you know that you are in the major cardiac vein. The distal aspect of the catheter is totally in the ventricle. So you are doing far field recording of the left appendage and the top of the left atrium, and that's why you see the A. So the distal, the earliest sighted when you start to see us, and that's exactly where the wave cardiac or this is downside of the left ventricle. I will show you an anatomic image for better understanding. It's the low aspect of the LV when it turns into the base of the ostium, and that's too basal, very close to the mitral valve. Do you have an anatomy slide? No, you have a break. After the break, I will show it. I will show it after the break. So we did a pace map. I won't spend any time on these, and I will ask Miguel to explain the vein, but the pace map gave us 93%, 95%. So we know from here that in order to find something better than this, it will be very difficult. And we are beginning to think about the approach to do the lesion. In any case, the second step, and that's what Miguel is talking about, is to say, well, there is a third dimension, endocardium, epicardium, and intramural. And in the venogram, you can see how we can map the perforating veins. What's important in order to understand the perforating veins is that you have to adjust the fluoroscopic projection in order to see them. Show me the right oblique with caudal angle. This is the right oblique with a caudal angle that separates. No, we place a Lima catheter for French, Terumo. And here we are doing the injection. What's good about the Agilis is that you can place the 3 French catheter and you still have some room for 5 French or 4 French. And in this case, we use the Terumo that we place through the sheath. We can introduce 2 catheters through the same sheath. Here we open the image to show the perforating veins. There are many of them with different branches. And we didn't do it in this case, but when you cannulate selectively one of those veins and you place a balloon, they look very abundant with a lot of collaterals, a lot of vein-to-vein communication. And it's important to understand the electrocardiographic projection. This is the right oblique caudal to understand the relationship to the anterior interventricular vein, the direction of the perforating veins. In the left oblique, we can see that the perforating veins don't go downwards, but they turn to the right. The perforating veins are moving to the left of the image and anatomically to the right. This is important because you have to understand that the ventricle has a circle shape. So the septum will be to the right, anatomically to the right, the image to the left of the anterior interventricular vein. Then what we did was to try to map the perforating veins to see whether we could get a better signal than the 13-14 signal. We didn't find a septal perforating vein at 13-14. They are more distal. So in this perforating vein where we are injecting, there we were able to advance the biotronic vision wire to get unipolar signals of the perforating vein. You can see it on the image, and it's late. We would have liked to find a vein at 13-14, but there are no veins at this point at that level. If we go back to the fluoroscopy, the perforating vein, and this is what we were discussing, and I was trying to convince Fermin, one of the perforating veins is displaced towards the base of the ventricle, 13 and 14. No, I just wanted to show them. No, but it's too small. Yeah, it's very small. The one that goes septal, no, base, the one that goes to the, well, here we see a basal, but we don't know whether it's septal because we don't have the left oblique. No, that is too proximal. Where we place the wire, the same one where we place the wire, it has a branch which is almost parallel at 180 degrees to the base of the ventricle. But we have not been able to cannulate that vein. And it would be interesting to cannulating in order to get signals from within the vein. Miguel, don't you think that you can cannulate more easily the angulated perforating veins with a cobra? Yes, what happens with cobra is that it's very short to pass it through the Achilles. No, but there have to be some longer ones in the lab available. Well, Fermin just cannulated a vein which is much more proximal, and let's see the signals there. Show me the left oblique here. Well, you only obey when I complain before the audience. Well, this is fascinating. In the right atrium, we don't see what is happening. The wire in the left atrium, we can see that it is moving towards the right side. Anatomically, it's fantastic. This image is fantastic. What signals do we have here? Is the wire connected? No, it's too proximal. It has a lot of A. No, just a minute, Miguel. Do you understand that this is too proximal? Basically, it's the same concept used in the multi-electrode where you find A's and B's in the wire. It's the same idea. Where do you find A's and B's? Well, here you have one further up. Fermin found one further up, but also with a lot of A. 1314 has A's as well, so that let's not rule it out. If you want to stimulate from the guide wire, since there are no extrasystole, no, it's below 1314. Yes, it's too proximal, I think. No, there isn't much artifact. I don't know whether we captured anything or not. Well, let's wait for the extrasystole to see if we get a signal. The problem of unipolar stimulation is the artifact. You must make an effort to avoid artifacts, and that's one of the things we have to deal with when we are doing pacing. Well, here we have an extrasystole to check because we are anatomically close to 1314. Show me in NAVEX the right atrium and the wire. Do you see the wire? Well, it's a wonderful place. It's a magnificent place. We need 3D. Could you please show us on the screen the 3D image? Yeah, rotate it a bit. Anterior oblique, rotate it downwards. So here we are in an intramural sandwich between the endocardic map that Fermin drew, the epicardic map of the anterior interventricular vein, and the wire is just in the middle. We don't have extrasystoles, however. Miguel, let me explain this to the audience. You can see in white the earliest zone of the endocardic map. And once again, this is a differential diagnosis. They didn't spend time doing all the ventricle. They just went to the area where they think, based on this multiple electrode catheter and the mapping. No, this is early. Look at the unipolar. No, I think that the unipolar is much better, but it's very close. Well, the thing is, Luis, look at the venogram that Fermin did. He injected contrast selectively on that vein. We stained the myocardium. I would love to be able to place a balloon and no, the cannula is occluding. Miguel, can you do a 3D reconstruction from the guide, please? Yes. Yes. explain the anatomy from the guide for anatomic orientation, and then we can start activating. Well, this is another advantage of the St. Jude system. We can do the anatomy from any lead and also from the guide. Well, this is an impedance-based system, so it follows the guide, and in that way we can reconstruct the basal perforating to get a better relationship. Because if for any reason you have an earlier result in the guide, that helps us to understand where the neighboring structures of the guide are. Well, here we can see the anatomy with the guide, and you create a virtual anatomy, intramural virtual anatomy. Well, the patient is breathing. Remember that the patient is breathing, but we are getting a perfect image here. Very nice. Don't fuse them. No. It doesn't matter. Try to find an extrasystole. Well, I want to ask you a question. This is the best moment of the case. I think that we can continue and don't take a break at this point. Yes, we are at the same site. So it seems to me that Fermin has the cannulation of a branch, and when you inject contrast, you can see everything intramurally. We see the staining of the myocardium. That stained myocardium would be treated with alcohol. And we could consider, if the signal is good, yet to be confirmed, because we don't have any more extrasystole. No, there is an extrasystole. No. We are too deep, I think. We are too deep. When we do the reconstruction, when the patient breathes, the system continues to take the anatomy. So this is an anatomic orientation, but the technician, of course, has to do a thinner anatomy. Otherwise, it would look distorted, and it's not so long. Late? Yes, this one was late. I think it's more superficial. Leonor, don't move. No, too late, extremely late. Another thing we will do is to place the opposing the ablation catheter opposite to the side we are. And when we have the extrasystole, the way to decide where to do the application is based, no, Fermin. Did you move the leads? Yes. Oh, it's the respiratory pattern that is changing. And this is an upward projection. Maybe we can move further to the left. Yes, but there is another extrasystole. We don't have such a good signal at this point. Show us the signal. Show us the electrograms in the revision screen, because what's important is for you to learn how to map here. So we need the electrogram revision page. Here you have the three modalities. You have the decapolar catheter, the endocardic ablation catheter. You must raise the gain. And here you have the wire. The wire is further away. The earliest is the epicardial catheter, and the endocardic catheter, which is in front of the epicardial catheter, as you can see, is as early as 13 or 14. Yes, Fermin, this concept is terribly important to explain. Explain the audience why you think that the first components is a far field instead of a near field, because that's fundamental for the interpretation of where you should do the early intervention. How do you conclude that this is far field and the decapolar is the near field? Well, here you can see. I'm going to put it at 200. This is the decapolar. The early activation is sharper, is 13, 14. If you place the caliper here, you move upwards, you see that the QRS, this is the activation. But I am going to remove these for the time being. The unipolar of the wire is not that early. This zone is worse. And this over here is not a sharp signal. It doesn't pass the midline quickly. It corresponds to this area over here, but it has a round shape. The real signal of the endocardium is this signal over here, but the catheter, since it's placed in the opposite side of the earlier signal, sees a far field of this signal. The idea is that when we decide this would be the earliest, this region would be the earliest. If due to proximity, we get a lesion which is deep enough to explain what is happening here, we can do it from the endocardium. And this is very important. Fermin. Could you place the ablation unipolar? The ablation unipolar. Well, what we're talking about now is essential to the interpretation of local electrograms. Where do you put the early activation time? What Fermin just mentioned is very relevant. One of the ways to understand the near field and the far field in complex electrograms is because of the frequency, which is the sharpest part. Here, it is suggesting that this is the local activation and not in the first part, which is low frequency. You can see that it's a non-rapid wave. And obviously, it's easier to understand if we place the unipolar at the same time as the bipolar in that area. Probably the unipolar here is beginning beyond the initial area of low frequency. And by comparing it with decapolar, that greatly facilitates our understanding to interpret this electrogram. These small details make a difference. In the end, you have a disproportionately large activation area rather than a specific area. Based on that analysis, probably Fermin would place the early activation at the beginning of the sharp segment of the electrogram, and the software is prepared to do that by default. You can say put everything at the beginning of the electrogram, and you may lose some parts. And then the fastest deflection of the electrogram, whether positive or negative, when we compare unipolar and bipolar, it is extremely helpful. Usually, the peak of deflection, whether positive or negative, of the major initial deflection of the bipolar is consistent with the maximum DDT of the unipolar. Usually, it's in the fastest area of the unipolar, and this is the way we do it. And the new softwares for automated records such as Rhythmia, etc., are based on the combined unipolar bipolar analysis. Any further comments? Well, we have to decide what to do now. Fermin, there is a question for you. We need a microphone for the question. Well, we are not going to take a break. We are enjoying a lot your case. This is a fantastic case. And I think that we are all learning in real time, which is the objective of EP Life. Well, the question we have to ask ourselves is to decide whether we will remove the whole system so that we can place the ablation catheter in this area through the agilis and do ablation from the catheter, because this is the earliest area. But there is a question for you. No, but what I wanted to say is versus giving an injection. But what concerns me about the injection is that we are not early in that area. Yes, we have to make some adjustments. The problem is that we have to have the wire just next to 13, 14, and it is too proximal now. I am trying to adjust the wire. The other option we had prepared and was part of the discussion is a very small coronary sinus. So the manipulation of the catheter has to be done through the agilis, but once we are there, the impedance will be high and difficult to apply from the vein. Have prepared that for the discussion because we have half normal saline available in the room. Well, let's hear Diego's question. Where is the ablation catheter? Fermin, can you show us the intracardiac echo, the eyes? Yes, we would like the eyes and fluor, the fluoroscopy image. Okay, they want to see the fluoroscopy and the eyes for the location of the catheter. Well, it's too basal in REO. It is exactly below. And what's important is to see the eyes because the fluoroscopy is what you want to see. But the only thing that doesn't lie is the eyes. So let's see the eyes. Here on the eyes, this is the ventricle. This is the anterolateral papillary. We move clockwise. This would be the beginning of the outflow tract. The catheter is too basal in front of the base of the left ventricle. This is the base of the left ventricle, as you can see in this area. Fermin, but based on the location of the catheter on the echography, aren't we in the endocardic aspect of the summit? Yes, but we are more towards the valve. Yes, more basal than required. Yes, this is the lateral aspect of the summit. Maybe we can connect the computer so I can explain to you where is the localization. I can show it in a second in my computer, but the option is, well, there aren't many stress-systole. That would be another discussion point, but let's get ready for the next step, either to place the evaluation catheter or go into the veins.
At this point, we have considered 3 therapeutic possibilities. They have used different tools for diagnosis. They started with the analysis of the EKG, and that exercise will be done by Fermin based on the slides that he has prepared for you. And the second thing, they used a multi-electrode catheter. And therefore, if they have already localized the earliest area, Fermin, please tell us here in the audience if, based on the location of the placement of the wire and the multi-electrode, you think, and what's your judgment, that the earliest area that has been recorded is epicardial, intramural, in what aspect of the left ventricle? And please prepare to tell us the potential therapeutic options. Endo, epi. Is the computer connected? Please explain that quickly, and let's try to make an attempt at an endo application. We are receiving our coffee break here in the room. We didn't want to leave the room, but we need to go on to Chief's talk because he needs to get on the plane very quickly. I'm going to be showing with the caliper here, but basically, okay. The LV summit that would be up here, right? According to the anatomy. And we know that the catheter would be going down this way, this way, this way, and becomes this area here. This extrasystole probably comes from here, from the lateral aspect, the most basal portion of what is known as the LV ostium, which is this green line. The LV ostium is this concept right here. If you look at the heart from the base, you see the LV summit, which is what is being marked by the yellow arrow. This is the LAD here, and it comes down this way. This is the vein around the mitral valve. This area is the mitral and the aorta, but since the aorta and the mitral have no muscle tissue, when Mahalman resects all these structures, all the valve structures, he ends up with this circle here, which is called the LV ostium. This rhythm that we're talking about doesn't come from the endocardium, the ventricle, but from this area that comes down from the epicardium, the lateral medial area, because this is not totally lateral, it's lateral medial of this region here, and hence the earlier activation is in the duodecapolar catheter, because it is here in the vein, and we are activating this epicardial area here. There's no use going to the epicardium here, because this would be full of fat, which is around the circumflex. So that is the application. Okay. We have to make a therapeutic decision, and I think that the ideal thing, the best signal always has been the 1314 of the duodecapolar catheter. My first option would be to try to place the ablation catheter right there in the distal CS, or in the most proximal area, and try to ablate there. And if needed, place the apical saline. If not, well, but that would be what we would do initially. Miguel, could you tell the audience which would be the therapeutic options to select from? We know that what you're proposing of making application in the interventricular, but what other options do you have in your hand? Well, a second option would be to ablate from the endocardium, in the best portion of the endocardium, which is where the signal is not so good, but anatomically assume that we can get to the origin of the extrasystoles from there. Another option would be to consider bipolar ablation, and we have also been experiencing with is to try to look for perforating veins and inject alcohol. Fermin found a very large perforating where we found a good signal from the beginning. But the problem of using alcohol in the perforating veins is that if we are going to ablate in the distal coronary sinus, we would probably be destroying the perforating veins, and it would be impossible to have alcohol as a second option. We would burn that bridge, and that's an option we have to consider. Okay, so we are going to be applying on the coronary sinus. I'm a bit afraid because it's quite a rigid catheter and it is a small coronary sinus. But it was a democratic decision, wasn't it? Yeah. In the best style of Fermin's. Okay. The ablation catheter is very proximal still. It's going to be very difficult to get there, even with the Agilis as we have placed it. We have opened another ablation catheter just in case. In the map that we're seeing, the 3D map, I think that you finally marked the earliest area, right? On the arrival of the interventricular to the great cardiac vein, which is close to the outlet of that most basal perforating. Yes, yes. We see a very significant angle here. It's quite an acute angle. No, a 90-degree angle, really. And you need to bear in mind what Dr. Valderrabano is mentioning regarding the rigidity of what you're using. Miguel and Fermin, do you have any experience using for this area a cryocatheter? You know that sometimes it has been proposed as one option because an RF catheter might have very high impedances. But if it is difficult to pass the RF, do you think that the cryocatheter is an option? I don't have any experience with cryo in the coronary veins. I do, but it doesn't work. Yes, because what we're saying, it's very angulated and it's very stiff, the catheter, in order to do a smooth navigation here. In view of the anatomic difficulty to advance the irrigated catheter to that place, to that area, and assure success, why not a left ventricular endocardial lesion in the earliest portion of the wire? Fermin, could you answer? Which would be the criteria that would suggest that it could be effective to go from the endo? Yeah, it's a good question because obviously we are important advocates of endocardial ablation, but I think that particularly in this case, we are not even early. That could be the second choice. I think that the best option, since we're so early here, would be at least to attempt it. If we cannot do it, well, we won't. But and the reality is that it is not easy. It's not easy. And obviously, the next step will be what you said, to do an endoablation. But the distance on the map and on the ice, there is less than 1.5 centimeters. So when you have a larger distance, in particular in this area of the heart, which is the basal area, the most basal area where there's a lot of muscle tissue, you need to apply large lesions. And I think that the key here to prevent complications is to try and predict based on the distance between one catheter and the other, try to predict. Yes, generally what is done is to do the measurement from the tip of the endocatheter and what you have in the epi. But what's the key? Based on the echo, you assure that you have very good contact, because that is what brings you closer to the epicatheter. If you're above 1.5, generally you're going to fail. If there are no other options, we end up doing that, yes, because if you don't have a way to apply on the epi or to use alcohol, it's the only way out left to you. Any comment, Fermin, regarding that if you go endo and you want to do more transmurality of the lesion regarding the prolonged application? Would you prefer radio frequency? To do that, we need to be very certain of the location and of the fact that you're going to have a good distance, because I think that the more distant applications you make with high power, the more risk of complication you have. A while ago, there was a case report on
el aspecto opuesto al Elvisomen, es decir, desde el endocardio, en donde aparentemente relacionado con eso, el paciente regresa meses después con un divertículo, ¿no es cierto?, en esa zona. Nosotros hacemos con mucha frecuencia aplicaciones prolongadas de alta energía para lograr, digamos, ablactar circuitos o
circuits or intramural circuits or extrasystoles. And we, to this date, haven't had any reported case of what I just mentioned. But indeed, what we do know is that you need to be as specific as possible, because filling the entire wall with prolonged application using high power and high contact ends up favoring the formation of a diverticulum. Fermin, I don't know if you agree with me. Fermin? in order for you to create a diverticulum in that area, you must have applied many times in that area. So what we propose as an approach is a combination of multi-electrode with a guide wire in order to reach the more specific site under guidance and concentrate there with longer 3-5 minute applications, but not filling the entire segment, the basal segment, with these kinds of applications, because this is what increases the risk of complication. It is not infrequent to have steam pops forming there, and we don't know if that is what favors cardioembolism. And remember that there was a recent paper published with a report of the fact that almost 40% of ablations in the left ventricle for arrhythmias, which were idiopathic initially, were correlated with small lesions in MRI of an embolic appearance. So what we are proposing is to map more, to do more entrainment, more pacing with multi-electrode guide in order to be more specific, and as we are more specific, be able to be more aggressive. We weren't able to advance the ablation catheter to the location we wanted to. We have a talk here waiting for us, so we are going to just move ahead, and we will be back with you in a while, okay? So thank you very much. Great work. Chief, where did Dr. Kumar go? Is he not here? Dr. Chief Kumar will be giving us his talk about neuromodulation for the management of ventricular arrhythmias. So we are going to switch to his talk. While he comes and connects his computer, to summarize then, what you've seen are the steps that we usually take for mapping and ablation of these arrhythmias. From the EKG, based on the EKG, and with the associated anatomy, we applied to the EKG. We tried to arrive at 3 differential diagnoses and try to make a restricted map of these 2 or 3 areas in order not to spend half of the procedure mapping what is wrong. In this case, we don't have to map the papillary muscles, for example, and this saves a lot of time. Placing multi-electrode catheters as much as possible, especially in these complex anatomic structures, to save time through the comparative analysis of where the earliest activation occurs. And third, having very clear how you make the complex electrogram analysis to determine what is near field and what is far field, especially in complex electrograms, especially cusps in coronary sinuses, etc., and to do some pace map. Pace mapping, in a way, we use it, but we minimize somewhat. We minimize its impact on the clinical decision on what to do, in particular in these areas where there are preferential conduction pathways and you might become lost. And later, try to imagine what is the best approach, and it is generally not one approach. Generally, we need to choose on whether we complement endo and epi applications, use of saline. In the second part of the segment of the session, we will go more in depth into the therapeutic options. So let us connect